Everybody, welcome back to another episode of the Fearcast. This is the podcast dedicated to OCD and anxiety spectrum disorders and getting your life back. I'm your host, Kevin Foss, and I'm a licensed therapist specializing in OCD and anxiety disorders. If you have a question for this, generally speaking, question and answer-based podcast, go over to fearcastpodcast.com and send a message to me over there. You can send a text message, which I suppose is an email. It's text, it's a message. Okay, you get the idea. But you can also send an audio question. You click on the button in the upper right of that page, you record your voice, it sends directly to me, and remember, voice questions go to the tippity top of the list. So you can send it that way. You can also go over to Instagram and send me a question there by sending me a DM. I am Fearcast Podcast over yonder, and you can send your audio question in the DM, press the little microphone button, and it will get to me. And again, goes to the tippity top of the list. Today's episode is not a question nor an answer. It is an interview. So I was lucky enough to have Dr. Jeremy Shuman on again to talk about neurodiversity. So he was on maybe a year and a half ago, to talk about neurodivergence and OCD, kind of viewing it as a neurodivergency. So he's on to talk about today, more specifically, OCD treatment for folks on the autism spectrum. So I'll share a little bit about him in just a moment, but this was a fantastic conversation. He's such a passionate person. He's such a knowledgeable person about this population and about treatment specific to those who are experiencing both autism and OCD. There's a lot of overlap that we'll talk about between those, and diagnostically it can get very confusing. And then treatment-wise, it can also get very confusing and or frustrating. But Dr. Shuman does a great job talking about ways to approach this, talking about kind of demystifying, actually, in a lot of ways, demystifying the concerns that people have about practicing ERP and CBT with someone who's on the autism spectrum, and really offer some encouragement to folks who are, interested and caring about that population, to kind of jump right in and to help folks who are in need, rather than being really concerned about the gatekeeping that may or may not be there or perceived to be there. So without further ado, without my yammering, let me tell you a little bit about Dr. Shuman, and then we'll get on to the interview. So Dr. Jeremy Shuman is a licensed psychologist specializes in OCD, anxiety, and neurodivergence. As a neurodivergent clinician, he is dedicated to advancing equity by challenging systemic barriers that limit access to public resources for neurodivergent individuals. Dr. Shuman works to shift clinical perspectives away from deficit-based models and towards an understanding of neurodiversity that honors differences rather than pathologizing them. Dr. Shuman practices in St. Louis, Missouri, as at the Center for Mindfulness and CBT. He provides neurodivergency affirming psychotherapy focusing on treatment-resistant OCD, teaches seminars in the treatment of OCD for graduate students, trains clinicians in evidence-based psychotherapy practices, and offers consultation to those seeking to better conceptualize or develop treatment plans for OCD and anxiety. He also leads monthly meetings for IOCDF's autism and OCD special interest groups that are open to anyone interested whether they are a clinician or a community member. While he can only provide therapy to individuals in Missouri, Dr. Shuman offers trainings and consultations remotely to professionals in any location. So, without further ado, here is my conversation with Dr. Jeremy Shuman. All right, Dr. Jeremy Shuman, thank you so much for joining us for this episode of the podcast to talk about a really important topic, which is CBT, ERP, and OCD treatment for folks on the autism spectrum. So thank you so much for joining us today.
Thanks so much, Kevin. I always like having a chat with you.
Absolutely. Well, I know I had you on a while ago to talk about what were we talking about? Neurodiversity within OCD. So this kind of continues that conversation and gets a little bit more specific to just folks who have been diagnosed with autism. I guess for those to kind of get things started, I'd love to maybe start with what is for those perhaps who aren't initiated or who are just jumping on this. How are you? What is autism? How would you define it, and what should we know about it as we proceed into this conversation?
Sure. Okay. Yeah. Autism is a neurodevelopmental condition, and there is sort of a grievance-based definition of it. and a phenomenology-based definition of it. I know I was talking about this on the podcast last time I was here. So a medical definition of autism is going to be deficits in social skills and these deficits in your behavior where you are repetitive in your behavior, and that causes issues. From a phenomenological, from a lived experience perspective, we might define autism as this cluster of traits around sensory sensitivity and using self-stimulating behaviors to regulate emotional intensity and find identity, and including preference for sameness, emotional intensity, communication differences. That these describe the profile of the traits that make up what it feels like to be autistic. But that cluster of traits sometimes leads people to have enough disability that then the DSM picks them up and says, okay, this is someone who gets a medical diagnosis.
Okay. All right. So help everybody understand, because I know there can be a lot of overlap in some symptoms that are often found within autism, and then also some symptoms found within OCD. And, that's not, the overlap isn't necessarily what we're talking about today, but I know that can be part of the diagnostic kind of difficulty between those two. And I'm curious to hear your perspective on differential diagnosis between those two.
Right. So the restrictive, repetitive behaviors that are part of the diagnostic criteria of autism sound a lot like the repetition of behavior that we would see in OCD. So if I'm a clinician or if I'm a parent and I'm just observing a behavior and I see that it's inflexible and repetitive, then it could be tough to tell what is the reason that someone's doing this. And listeners of your show might already know the concept of what's the function of a behavior. So we would ask, what is going on? Why is the person doing this behavior? How is it functioning for them? And things that are neutralizing obsessions, where there is sort of like a fear that is out of proportion to any actual risk, and then it gets neutralized through a repetitive action, that is going to be our OCD stuff. The stuff that is going to be autistic, it's generally going to be stuff that's instead of worsening anxiety through the neutralizing process that reinforces, it's going to be stuff that adaptively copes. So we're going to see it functioning to regulate arousal effectively over the long term, much more effectively than when we take things away. So the really common ones that get mistaken are these ones I'm already raising. So it is special interests. Autistic people tend to have a preference for some content that they enjoy, some idea. It could be a character, could be a sport, could be people like spinning things. There could be any number of things that someone could really get into. And then colloquially, we might think that person is obsessed with this, but that's not the way that we use the word obsession in OCD. Yeah. And so that would be a way of like saying, oh, they're stuck in a repetitive behavior, but that's not what's going on. And the next one would be sensory sensitivity, where we see a person avoiding something because they're saying that they have sensory overwhelm from it. And in OCD, a lot of times we'll see people have a story about why some stimulus is going to be impossible for them to tolerate. And we might assume that there's an obsession there when there really is sensory intensity that makes this uncomfortable. And through repeated exposure, we might gain in some grit and ability to face that intensity, but we're not getting any desensitization of how aversive the stimulus is. So it's not exactly like OCD, where like when we do the exposure, the fear comes down. And then stims, spins, and tics are often thrown in this, but those aren't autism, but those that can be comorbid with other forms of neurodivergence, where people have a repetitive motor behavior, and it can be assumed to mean that they are doing it to prevent harm or to neutralize some not just right feeling, but it's not functioning that way.
Right. So for my understanding, I'm kind of hearing a big difference there between, what for OCD, some of the repetitive behaviors have to do with eliminating an anxiety or kind of in service of a feared story, versus for someone with autism, it would be a repetitive behavior, but it's more of a soothing or an adaptive coping skill to overstimulation.
Right. Overstimulation or understimulation. If I'm bored, I can use that sensory input to get to that optimal level of arousal and stimulation. Yeah, that is how we're defining it. Now, where it gets tricky is when something starts off adaptive, and then we develop that obsessional narrative around it to where now it gets wrapped up into a compulsive behavior, that it was adaptive when used in one way, but when it's used to neutralize, it stops being adaptive. And that can be tricky to navigate.
I believe it. When do you start to find OCD starting to show up alongside autism diagnosis? I know a lot of times, or I believe part of the diagnostic, and you can tell me if I'm wrong on this, symptoms occur once they're 3 and past. That's when a diagnosis of autism can show up. Is that correct, or is that inaccurate?
Autism gets diagnosed throughout the lifespan. You're rarely going to see it diagnosed younger than 3, because it's just hard to see the behavioral manifestations of it. I've heard of people diagnosing it as young as 2, or maybe even potentially 18 months. OCD shows up at these more common times, right? Boys tend to get it as they're entering into adolescence, and young women tend to develop it around the time they're graduating high school and into young adulthood. Of course, it can show up at any time for any trigger.
For some of those early interventions, I know we briefly touched on the early intervention techniques for folks with autism once they're officially diagnosed. Are there some for maybe folks who are families who are going through the early intervention process? Are there some things that families should look out for, or people who are practitioners in early intervention? Are there some things that they can look out for to help differentiate between just run-of-the-mill, as it were, autism symptoms versus when OCD is starting to play a role?
Yeah, I'll pick out one thing in specific, which is what I'd call fundamental change intent. Fundamental change intent. Are we altering a behavior because that behavior is not working, but who you are authentically as a person is not changing? You're just finding another way of navigating the world. That is a helpful behavioral strategy. Versus fundamental change intent, we have some promise that if you do things in this new behavioral way, it's going to change something that's intrinsic to you, and your wants and your desires and your needs are going to change. So when we're looking at, am I doing early intervention for my kid, and I'm trying to discern, is this person going to be helpful or not? And thinking OCD tends to show up later. We're always going to be sensitive to anyone who's promising, if they do this pattern of behavior over and over and over again, it's going to fundamentally change what their needs are, because they're really just learning how to get their needs met. It's not changing what their fundamental needs are from the beginning. And this starts to get into what I say is like, we are looking for clinicians, not technicians. A clinician is someone who evaluates and understands conceptualization of what's keeping this person stuck, and then is coming up with these fundamental learning tasks that are going to change the way that the person interacts with the world because they've seen a new possibility. And a technician, they're just going by the book. They're just, if you see this behavior, you do this intervention. And so if we're not stopping and asking the function of these behaviors, we're going to be prone to making these sorts of mistakes. So when I say the thing I look out for is fundamental change intent, I'm looking for a clinician, not a technician, because I'm worried that these technicians are going to say, well, it's not working the way that you expect it to work, but if you keep at it, it's going to make this difference. They haven't really assessed what the function is, and they're hoping that through repetition that the person is going to extinguish this behavior that was really fundamental to what was keeping them authentically feeling safe and grounded. And there's not going to be coming back from that. So we would watch out for that.
Right. Okay. So to summarize, it sounds like to kind of slow down in the process of working with somebody and think about what they're seeing, some type of behavior, to ask themselves, why is this person doing this? What are they getting out of it? What function does it serve in their life? Is it helping them in one way? Or in what way is it helping them? And then in turn, in what way is it harming them, or in what way is it hindering them?
Exactly. Yeah, and let's even go further with that a little bit. Yeah. Okay, so if someone has OCD and their rituals are disturbing the family's function, we want to function as normally as possible and show the person with OCD, you don't need these accommodations. Life works out really well when we don't have these accommodations. So we don't really want to do a lot of negotiating with OCD. We're going to treat it more like a terrorist, or we're not giving it very much. We might shape the behavior, but eventually we want to get rid of it. With autism, it's not going to be the same thing. It's going to be a negotiation. It's going to be, how do my needs meet with the needs of my family? So for an example of this, if I've got a kid who is verbally stimming and they regulate their arousal by making loud noises with their mouth, that's going to disturb people who are trying to work in their classroom. And that's going to, that's a difficulty. So how are we going to navigate that? So if it was OCD, we would just say, you don't need this. You don't need anything here. If it's autism, we're going to say, what is getting lost if you stop this verbalizing? So we might have to negotiate something where the class is getting its needs met and the individual is getting their needs met as well, in a way that we would never think to do for OCD. So that's where the clinician is going to be helpful. It's not going to be, it's autistic, so just let them stim freely, even though it's
whatever they want.
But at the same time, we're not going to say, take away this, because they don't need to stim. They need the stim, but we need a better plan for how they're going to navigate school with their stimming need.
And I can already see the murky mess that this can be for somebody, where, on the one hand, we would say, don't give into accommodations. We say that for OCD. But then on the other hand, what can feel like then is we're making accommodations for a behavior that may be disruptive to the family or to the class or to the group or whatever it is. And, to really differentiate between the two, this is where a really skilled clinician and thoughtful work on, I would imagine, on the family and the individual comes into play too. Because I can certainly hear where, if we're saying, all right, for a STEM from an autism perspective, let's go with the verbal one, right? There, it may be auditory, it may be something with, it feeling good to make a loud noise. It may feel good to tense the parts of the body that are making that. What are the ways? We could go on and on, but there's something pleasurable about that. From an OCD perspective, if someone's making a loud noise, likely they're making a loud noise to satisfy or to reduce anxiety in some type of way, and they're trying to do it either in a just right, or a number amount, or a volume, or something.
And they're frustrated that they have to do this. And if I could just feel right without doing this, I would much rather avoid the embarrassment and avoid the discomfort in my throat from making the noise. Whereas the autistic person is like, I just wish no one else was around. I would do this if I felt good, if I felt neutral, or if I felt bad.
Yeah.
I think just enjoy it.
I've heard one of the differences for a behavior for OCD, it's someone doesn't like the behavior, but they like the result. Whereas the individual, what I'm kind of hearing for to draw a difference, someone with autism, they might not like the result of it annoying family and friends, but they like the behavior itself. I guess they like the result that it produces within their body.
Yes, that's pretty true. And of course, it gets murky, right? Okay, so let's say I've got I really like things to be tidy. That's part of my autistic preference for predictability and similarity. So I tidy things up all the time. And then I'm starting my tidying routine, and I get an OCD not just right experience about how I've just tidied. And so then I have to write it. Oh, it still doesn't feel right. I'm going to do it again. Oh, I still have to write it. Do it again. And okay, now it's getting confusing. I'm someone who likes tidying. So I like the behavior but we're still saying it's ego dystonic. But in that case, it's ego dystonic because I want to tidy the way that feels good to me. And once the NJRE got involved in it, it stopped feeling good to me. Now I'm doing it in distrust of myself versus doing it because I like this behavior. So it's the behavior that I like, but the reason I'm doing it became distrust of self. Well, we still got OCD in the mix there too. Yeah. But I find that patients can be really good at identifying this for themselves. Now, about 50% of autistic patients have intellectual disability. About 50% don't have intellectual disability. We're going to have a wide variety of insight about how well people can verbally express the function of their behavior and the cause behind things. But I have in my practice, I don't underestimate people, and people become very, very good at it. And sometimes it takes many, many months for people to get good at it and to pick up the language and to understand how to do a functional analysis on themselves. But often it happens even with, I'm working with a young adult with mild intellectual disability who's doing great on this. And the turnaround from the way that he used to describe his compulsive mental ritualizing to now saying, like, well, I don't want to use OCD's language for that, was really, it just really is a testament to not underestimating our clients and giving them a chance to think like clinicians themselves too.
I love that. I guess why don't we jump into the treatment itself? And we were talking in advance about this, where there can be a misnomer that folks with autism won't benefit from the traditional kind of gold standard of treatment for OCD, which would be cognitive behavioral therapy, exposure and response prevention, and I think we might tie in mindfulness-based approaches, ACT, et cetera. But it's certainly CBT, ERP. Yeah. Tell me a little bit about that.
Yeah. This is so fundamental to what gets me out of bed in the morning and like what gets me fired up and impassioned about this work. Autistic people online have created a lot of communities supporting each other around mental health. And there's a lot of exploration about the variety of treatment options and strategies that are helpful or not so helpful to people. And there has been a social movement amongst autistic people, and this is like particularly within the neurodiversity paradigm, that says that CBT is more harm than it is good for autistic people in general, but then specifically exposure and response prevention gets like a really bad name. Now, where does this come from? A couple places. The history of applied behavioral analysis and autism has created just a huge amount of disagreement, particularly like within the clinical field, where some people say that the behavioral learning that happens through ABA is a lifesaver and gives people skills that allows them to function at a level that they never would have been able to, and allows families to have the freedom that they otherwise wouldn't be able to. And then there's another group of people that say that these behavioral strategies just alienated me from anything that was authentic to myself. I got trained not to be myself by being punished for anything that's authentic and being reinforced for these compliance-based behaviors that weren't really what my wants were, but I knew it was how I needed to navigate a system. And and the history of ABA before that includes the Omar Lavas, who is the originator of it, his involvement in conversion therapy, trying to get gay people to behaviorally become straight, which we now think of as being like so against. This is that fundamental change intent. It's like so problematic.
Bonkers. Is bonkers the word we use?
Yeah, that should be. And he had some quotations about autistic kids just not being fully human, and they need this sort of training and development to become human. Now, later in his career, he used better language around it. And ABA is such a well-developed field that we have a lot of clinicians saying, don't throw out the baby with the bathwater. But we also have a lot of clinicians saying, if the baby is the brand name of ABA, I don't want it. Like, let's toss this out. We can keep some of these individual strategies, but the stuff that is like, you don't get access to what you need until you've done the compliance behavior feels very much at the root of ABA. And just those three letters together are going to evoke like this, trauma reaction in folks who, even if they haven't been through it themselves, sort of like a vicarious traumatization. Mm-hmm. So that's one reason. And then the other reason would be the cognitive side of things, where we've seen that cognitive therapy has become slightly less effective over time. People use mindfulness-based interventions as to make up where just like you're thinking about this all wrong hasn't worked for some people. And that's a really common experience for autistic people, that they have some value that's violated and they feel distress over it. And someone says, you're thinking wrong about this. And they're saying, you're asking me to fundamentally change what my values are. I can't do that. That would be just gaslighting myself. That would be trying to trick myself to say I'm okay with something I'm not, either if it's about values or it's about how aversive some sensory discomfort is. There's no tricking myself into thinking that it's okay. So we have this, for good reason, anti-CBT notion. But those of us who do a lot of CBT know how to be a clinician, not a technician, and not push people into doing exposures where we think the prognosis isn't good and what the fundamental learning task is not something that the client values. And we know not to dispute, especially OCD, but we don't dispute anxiety with just, oh, you're thinking all wrong about this. We want to find what is true for the client. And if cognitive therapy isn't the right intervention because their appraisal of it is something that they really just agree with, we'll let go of that. But that feels kind of defensive, where people are saying we have this community trauma at the hands of CBTers, at the hands of behaviorists, just to say, hey, these problems don't have to be there, doesn't fully answer the question enough to get everyone on board. It doesn't lower people's radar for harm could possibly happen if I do CBT. And I think that's for good reason.
Mm-hmm. Yeah. So, it sounds like there's been this kind of, through people's lived experience going through that, there's kind of been this maybe mixed experience that some people maybe found it helpful, but a lot of people, or some people, whatever degree, have found it really harmful. So then that kind of extends the stank onto CBT, which that's what the B stands for, behavioral. So I just don't want to do anything that has to do with behavioral work. So there's already going to be this antagonism to the treatment itself.
Right. And again, I think for good reason, because of the history of how autistic people have been treated with what is going to be most helpful to you is this, again, fundamental change intent. Is we're going to fundamentally change you. And there's a big reaction to that. And so it's up to the behaviorist now to figure out how to respond, because you and I, who both practice behavioral things, we want to make sure that people get access to this life-saving kind of care. And it doesn't feel fair to people to say, well, you have a good point with how it's been harmful to someone else in the past, so don't touch this at all. And we're going to go to like the less evidence-based care when we know the effectiveness that this can have.
Right. Now, there can be this whole other mindset that folks with autism can't benefit from ERP or CBT for that matter. Can you speak to that belief?
Yeah, there's a couple pieces to it, and one of them is that autistic people can't find a window of tolerance with exposure. That all exposures are going to just shoot you through the roof of your distress. And we're not doing any learning in that, above our window of stress tolerance. I think that there might be truth to that, but that's why we design exposures to be within window of tolerance, and we make things easier until people are ready for harder things. And there's all sorts of ways that we can shape what the exposure looks like so that the person is getting, a fair shake of that. And then the other complaint is that autistic people don't habituate. And I don't know if we've had this conversation, but I get into a whole thing about what does habituate mean versus desensitize. Habituate is about no longer giving a behavioral response. Desensitize is about reducing the phenomenological experience of like how intense that stimulus was perceived. I think a lot of what people are saying is autistic people don't desensitize, but they're missing out on so much research that's come out of occupational therapy, that's come out if you work with kids doing this kind of work. I think the most telling one are some of the like brushing techniques on the back of kids' hands that help them deal with sensory hypersensitivity. And if you've seen kids before and after that, there's just no denying that absolutely it's not just a behavioral habituation, no more complaining. It is less aversive through that repetition. So it's possible that autistic people desensitize more slowly, and it's true that they desensitize incompletely, so that it's anything that was perceived as being too intense, repeated exposure to it, it's not likely to bring it down to a level where it's like, oh, this is easy and tolerable now. But it's not saying that the only way that we can get better at tolerating these things is through improving our grit, so where we're basically tolerating torture every day. But that is a belief within the autistic community that there's just going to be no desensitization. That's not what the evidence says. That's not what my experience is. I think that people's lived experience with seeing their sensory stuff not desensitize or incompletely desensitize leads to that kind of like all or nothing thinking about how that's going to be approached. It is something that we should consider. It's not something that rules out the gold standard treatment, in my opinion.
I've also got to say, I think that's my favorite description between, or differentiation between habituation and desensitization. I appreciate you drawing that too. So you also talked about the brush technique. Can you you brushed over the brush technique? Can you talk a little bit about what that is and why, and kind of why that's a great encapsulation for desensitization?
Yeah, I think I should defer to an occupational therapist who does this day in and day out, because I don't do this with families. I've worked with families who have done this, and it's a touch sensory sensitive kid who doesn't like any kind of touch gets a prescription for a parent sitting down with them at a regular interval and taking a soft brush and brushing on their arm or hand and doing it for a certain amount of time. And then on the other side of it, that kid probably is still touch sensitive, but less so, where those first few times where we're doing the brush, it doesn't feel like intimacy. It doesn't feel like a great connection. It can feel kind of overwhelming. But the more we practice it, it starts to be a pleasurable thing, and we can actually see that desensitization happening in real time.
Right. This is someone who may have sensory integration concerns or sensory sensitivity.
Correct.
That kind of what you're talking about? Okay. Yeah. So this is where, some folks with autism may, have issues with, I've certainly seen this where kids have concerns about, or, real problems with certain fabrics or the tags in their shirts or, things like that. And it can feel, I don't know. It's the best I can imagine. It's like having, wearing your shirt, but inside your shirt, there's incredibly rough sandpaper right up against your skin. And to say, well, just get over it because it's nothing. It feels bad.
Right. To rub sandpaper on their skin over and over and over again, the shirt is not going to become comfortable all of a sudden. But also to say, you can't touch these fabrics ever. It's not giving them any agency. It's guardrailing them away from things that they're capable of, and it's furthering them into disability. And I appreciate the disability that comes with autism. And this is not, let's make your disability invisible, but it's let's, I always make this statement about you shouldn't have to climb Mount Everest to get to work every day. Like, I'm not asking people to cope with intense things, but if every time you went to hang out with friends and people want to shake your hand, people want to give you a hug, people want to brush up against you, and that feels completely intolerable, doing some of this stuff when you're younger makes those experiences feel so much less intense. Even if I still cut the tags out of my shirts, or I don't buy the shirts that are made with the fabric that's non-preferred.
Yeah, there can still be some reasonable reasonable adjustments to life to make it more livable. And everybody does this in life in one way or another. Why wouldn't we extend that to someone with autism?
And the answer is because of the all or nothing thinking, because we have clinicians who are like, you're going to get over this with enough exposure, and they're wrong. And we have clients that are like, this is always going to be hell on earth, and they're wrong. And the truth is lying somewhere in the middle. And without being able to negotiate and like create enough safety for both parties to have this conversation, we're just missing each other.
Yeah. So I also don't want to gloss over this. You were talking about ERP for folks with autism and OCD. I really want to hit this point. You said ERP does work. It may just take longer.
Yes.
Okay. Can you expand on that just a little bit? I don't want to make it rehash.
Yeah, we have a lot of data of working with autistic folks with OCD where their Y-box score improves through ERP. So we know that it works. It helps people. And then subjectively, having worked with so many people, like I know that it's not just masking. It is, thank you. I don't believe in these fears anymore, and it really does help. On that anecdotal point, why it takes longer. There's a couple reasons it takes longer.
Okay.
One is that slower pace of desensitization. That's an habituation. It takes longer for folks to not give that behavioral response because it's just that pace of desensitization is slower. Another is that the autistic person is likely to have like a higher level of baseline anxiety, and that concept that we were saying about the window of tolerance, where we try to set exposures to be within a tolerable window. It's not too easy where it's like a walk in the park, but it's not too hard where I'm white knuckling and not learning anything. That window of tolerance might be kind of smaller because of that baseline anxiety. And so we might need to do that really slow, graduated approach to gain confidence. Further, with this idea about predictability and novelty being distressing, it's just even more reason why we're doing more repetition before we're moving up a ladder at all. It can also be it can take longer because the way that we conduct sessions may not feel exactly the same. So if I'm a specialist who's doing OCD therapy, I get someone who's come out of another kind of therapy and they're like, yeah, I want to work on my OCD with you. And we don't spend that much time talking about their childhood or what's going on with, their partner, if it's not relevant to the OCD. And we can just kind of do this targeted work and like get right into what the homework is going to be. A lot of times working with autistic folks, we see that their communication style is different. They're going to want to do more info dumping, and they're going to want to have more personal connection before they're going to feel comfortable to have a conversation about these goals that they might have for themselves. So incorporating their special interest, people want it to be that, okay, we incorporated your special interest into OCD work, and now the session is on target on working on ERP goals the whole time, just using that special interest as the lens that we look through it. But more often what we see is that, sometimes we need to do longer sessions so we can cover all the material that we want. We need to not just incorporate your special interest in, but let you be, regulate by this, by exploring your special interest throughout the session. Let the relationship with the therapist be around this like mutual understanding of what keeps you safe and regulated. And that's all time that's spent not doing exposure. So that can just prolong things. A common tip to modify ERP is create a visual schedule. So I walk into my therapy session and we start by saying the first 10 minutes, we're going to talk about the week. And then for 5 minutes, we're going to talk about homework. And then 35 minutes, we're going to do exposure. And then 5 minutes, I'm going to do a checkout with you, and I'm going to color code this, and a visual thing that you can see. That is great, but also sometimes we just need to do a 90-minute session, and we'll get more out of that 90-minute session than we will out of trying to fit that square peg in that round hole.
Yeah, and I think to that end, being being really adaptive to that individual. It's not like, what is, I'm going to adapt or say it wrong. You've met one autistic person,
Mm-hmm.
right? So part of that is being adaptive with that individual and finding out what that person needs, because, folks without autism, sometimes a client is going to come in, and rather than just being business bear and just getting down to ERP,
Right.
you need to spend 10 minutes talking about the weather or how terrible traffic was or work or something like that.
Just a sensitivity about current events. I mean, that's what all my autistic clients are coming in this week. There's like a big current events week, and you're here to do ERP. But if I just say, hey, in this dysregulated state, let's ignore what your concerns are and do ERP, I'm losing them. We're not getting learning happening in that. So we have to find our way back to it. And if we don't find our way back within session, that might be appropriate for the best way to use our time to keep the relationship and keep the person motivated and having agency. They want to work on this instead of feeling like they're being dragged through it.
Yeah. So I think being flexible with someone and I think is paramount. But let's see here. I know we want to talk about ERP and combating horror stories. Did we effectively handle that, or are there other aspects that you wanted to hit on?
I want to touch on how tolerability research is done for ERP. What we see is that there are a bunch of studies that show that ERP is effective and a bunch of studies that show that it's tolerable. How do we show the tolerability that ERP is tolerable for autistic clients with OCD? We look at things like dropout rate, and we look at if parents afterwards said that it was tolerable. The tolerability coefficient that they use is pretty similar to the tolerability coefficient for getting deep brain stimulation for OCD. So on the one hand, that means that deep brain stimulation, getting the surgery where you put probes in your brain, is more tolerable than people might imagine. But on the other hand, most therapy that people really like is more pleasant than that.
I hope.
Yeah. So I think that the way that we have been asking the questions about does ERP harm autistic clients has a foregone conclusion, where only folks who are signing up to work at a university to do a trial of intervention at a university lab are being asked, how tolerable was this? And there's a lot of people who wouldn't have touched this with a 10-foot pole that just are getting left out. So I want to see research done where we ask people who say that they had a negative outcome from ERP, what was that negative outcome? What caused this for you? What do you want other ERP therapists to know? And that research is just not as much of it. Christine Purdon in Canada does a little bit of that research, but it's not about autistic clients. It's just about the 40% of people who don't respond to ERP. Why, what led to their dropout? But I want to see that research done for autistic people, and it probably needs to start qualitative, where we're doing interviews, and then move on to the quantitative research after that. Is not a popular topic in the research community.
Someone out there who's listening to this, if you are looking for a research subject, that's something to do, and you'll get tenure in it somewhere. Just keep doing it. So, okay. So one of our last points we want to talk about was, how do we keep treatment safe, keep ERP treatment safe for autistic folks? What does that look like? And it's an interesting word, to keep it safe. What do you mean by that? I think
it's all the stuff we've discussed today. Okay. That we keep it safe by not assuming that we're fundamentally changing the person. So we're respecting their traits and not expecting them to change. We're keeping it safe by doing a really good differential functional assessment of every behavior, and not just assigning behavior to one diagnosis or another and saying, if it's repetitive, then it's OCD and we're going to extinguish it. We keep it safe by recognizing that the sensory intolerances don't habituate. And so we have to keep people within their window of tolerance. And that involves making a sensory safe experience for people who are going through exposure therapy. We make it safe by being so aware of how there's a demand characteristic that we as the authority are saying, you're going to get better if we do this, and stepping back from taking a complete expert role and being more the advisor and giving people agency in how they choose to do their therapy, so that people aren't going to hurt themselves. People are going to be able to feel like they can give us feedback that this one isn't working, and it's because I think it's one of these cases where I'm being asked to change something that's fundamental to me.
Mm-hmm.
These are some of the general things. And there's a lot of great presentations out there. IOCDF has on their YouTube a presentation from Rebecca Sachs and Andrew Guzik that is about modifications to ERP that's really good. I host this monthly special interest group meeting. We've had a speaker come and discuss modifications there. I have a training on neurodiversity university about this stuff. Fred Penzel has a training that's on the IOCDF website. If you prefer to pay for your trainings and don't want to watch them on YouTube, that's where you'll get this stuff.
Love it. And there's so much more information out there now than there ever was. I remember trying to, like 10 years ago, trying to find information on this. And I think there was like one YouTube video from Rebecca Sachs. And that's where like my takeaway was ERP works. It just takes a little bit longer. And it's that was all the encouragement I needed to, get me going in that. So there's so much more nuanced information out there. Can you talk a little bit about the special interest group that you run, and who would benefit from joining that group if someone out there is looking to get connected or looking for more information?
Yeah, thanks for plugging that. I shouldn't say that I run the whole thing. I run the monthly meetings. There's 5 leaders there, so there's a lot of.
It is the Dr. Jeremy Shuman show. All right, go ahead.
But it's really open to anyone. Anyone's welcome to attend. So we typically have a mix of clinicians and supporters of people with OCD, and some people also with OCD and autism themselves, but it's open to everyone. We alternate where we have a speaker one month, and then the next month we do an Ask the Experts panel. Just gives people a chance to off the cuff ask their questions, and whoever of the SIG leaders show up will give you off the cuff responses. Anyone who's interested in getting involved, if you have questions that you want to get answered, you could attend one of the meetings and ask the questions. If you're interested in speaking, you can send me an email, jeremyschumanpsych@gmail.com. I'll try to get you on our calendar of presenters. If you're interested in doing any writing, there's a resource center on the IOCDF webpage. We can get your writing posted up there. If you have even just like, I want to see these questions get answered in short and sweet ways. Some of the SIG leaders were trying to come up with a video series of like 2-minute answers to some of the most popular questions. Send me those questions and I'll incorporate that into the series that we're producing. But it's multi-potential. We can do with it anything that someone is hoping for.
That's amazing. Yeah, having that available to folks is huge, but also having the flexibility, being able to kind of make it whatever you want. So if someone out there has an idea, I want to see this, I want to hear someone talk about this, message them. They'll likely put something together for you.
Yeah, within the next year. I mean, our content calendar is not entirely full for next year, so we still are taking suggestions. Yeah.
Now's your chance. Awesome. Well, I
got one more. I got one more thought for you. We didn't touch on the ICBT stuff. You said,
"Oh, that's right, it did."
How do we keep? And I don't want to make that the point of this episode, because there's not a research base for using ICBT with autistic folks. There is a research base for using ERP with autistic folks with OCD. But anecdotally used sort of as there are good reason not to use the gold standard treatment. I have had success with a number of patients. Now, there's a number of patients I have not had success with ICBT as well. But folks are interested in looking into that. There's some generally, helpful stuff throughout all the ICBT curriculum, but also there's a woman, Brittany Goff, who's done a bunch of trainings about how ICBT can be applied when working with neurodivergent clients. And I mean, we all have our different, since this is not we have a research project and we can clearly say this is what there is the most evidence for. We all have, some different opinions about the application of this stuff, but all the work that Brittany has poured into creating materials, I find it to be extremely valuable. And there's a lot of cognitive therapy suggestions for things that you can do in there that some of your clients might really find valuable. It's not ERP, it's not behavioral. And it's nice to have options so long as we are not guardrailing folks away from from probably the most effective options.
Right. I think it's important to acknowledge that there are other options out there, because some folks will get into ERP, find that it's, as you said, there's a not insignificant percentage of folks who don't respond well or don't respond at all to ERP. So there are other methodologies out there, but that's not to say that ERP is not effective. There's a reason that we keep talking about it. There's a reason that we keep practicing it, because it is helpful. It is effective. So, but yeah, I appreciate you sharing that little bit about ICBT. So, is there anything else that you'd want to add? I want to be respectful of your time. I know you've got a life to lead.
I hope that if there's any clinicians listening to this show who don't work with autism, who do work with OCD, but they don't work with autism, that they might take a moment to think about whether they are a clinician or a technician. And if they identify in that clinician camp, that maybe there's less of a growth edge than you might expect to up your competency and be able to do some of this work. There's a lot of common sense and judgment in doing this functional analysis to see how are things working for people. And I'm sad to see all the siloing where someone says, I'm good at this, and then this is all I'm going to do, because there are so many autistic people with OCD out there. And it's something like, I'm blanking on some of the percentages off my head. It's like 1 in 34 people is diagnosed with autism these days, and something like 17% of autistic people also have OCD, maybe up to 39%. We're talking about like millions of people who need these services, and I want as much as possible for them to have access to it. So if you are someone who thinks, I'm in that clinician camp, I'm pretty good at doing functional assessment, you may not have as far to go to learn how to be accommodating of these autistic traits as someone who is in the autism world, and they've learned a lot about how to accommodate someone's neurodivergence, but they don't have the background in behavioral learning principles, and they don't know how to find that window of tolerance and do exposure therapy within it. So hopefully some FearCast clinicians will say, it doesn't really sound that hard. It sounds like the kind of stuff, Jeremy doesn't sound like he's read a million textbooks that I don't know. And this information is out there. And with a couple hours of training, I think most people can get a hang of it.
Yeah, it takes a little bit of training and some thought about it, but it's not inaccessible. It's not magic. It's applying the work that you already do and applying the work you already do.
Yeah.
So exactly. Awesome. Well, Dr. Jeremy Shuman, I'll let you go here, but I do appreciate your time. And if anybody out there has any questions, I did not ask you this in advance, but I'm putting it on you now. If anybody out there has any questions to Dr. Shuman, to Jeremy, about autism, about the overlap between autism and OCD, about treatment for such things, if they message me, would you be willing to jump on to answer some questions about it?
100%.
Love it. Awesome. You heard it here first, folks. All right. Well, thank you so much for your time and your expertise, and again, your passion in all this. And have a good day.
Yeah, great. See you next time, Kevin.
See ya.
Bye.
Thank you for listening to the FearCast. If you would like your question answered on a future episode, please click on the Submit a Question link at fearcastpodcast.com. If you would like your question answered sooner, please send me a recording of your question to questions@fearcastpodcast.com, or by sending me an audio message through Instagram by DMing me at fearcastpodcast on Instagram. If you like the FearCast, please write a review on your podcast platform of choice. Please remember that the Fearcast is not a substitute for psychotherapy. If you need a little bit of help in your recovery, please go over to fearcastpodcast.com and click on the Find Help link, and there's going to be some information for you there. So until next time, take a risk, challenge yourself, and don't take your brain too seriously. Bye.